Hello everyone, myself Dr. Sandeep Sharma. I am a consultant at Human Mechanic Clinic and I specialize in musculoskeletal conditions. Today, we will discuss about physiotherapy management in treatment of trochanteric bursitis in Comrades Marathon Runners. What is a trochanteric bursitis? Trochanteric bursitis, also known as greater trochanteric bursitis or greater trochanteric pain syndrome, is a common disorder and frequent cause of lateral hip pain. The bursa, a small fluid-filled sac, acts as a lubricating medium for nearby gluteus tendons to gracefully slide over during the physiological range of motion. The trochanteric bursa is located on the lateral aspect of the hip, lying superficial to the hip abductor musculature and deep to the iliotibial band. Due to its superficial position and proximity to large tendons, the trochanteric bursa can become inflamed and is a common pain generator and a common reason for the presentation to the orthopedic surgeon or family physician. Inflammation to the bursa can be due to repetitive microtraumas such as running or exercise, tendinopathy of surrounding musculature, gross trauma including a fall from a height with direct compression to the bursa, or inflammation can be idiopathic without a discernible cause. Now we will discuss about pathophysiology. Repetitive friction between the greater trochanter and iliotibial band syndrome causes microtrauma in the greater trochanter at the level of insertion with the gluteal tendons. Friction leads to local inflammation, degeneration of the tendons, and increased tension on the iliotibial band. It is believed that chronic gluteal tendinopathy arises from the disorganization of the collagen bundles, hypercellularity, increased proteoglycan synthesis, and neovascularization. Studies have shown that there is a reduction in type 1 collagen and increased production of type 3 collagen in the gluteal tendons. This combination of collagen leads to poor fiber crosslinks with subsequent deterioration in the mechanical strength of the tendons. Now we'll discuss about the types. Bursitis is inflammation of the bursa. There are two major bursas in the hip that typically become irritated and inflamed. One bursa covers the bony point of the hip bone called the greater trochanter. Inflammation of this bursa is called trochanteric bursitis. Another bursa, the iliopsoas bursa, is located on the inside, on the groin side of the hip. When this bursa becomes inflamed, the condition is also sometimes referred to as hip bursitis, but the pain is located in the groin area. This condition is not as common as trochanteric bursitis, but is treated in a similar manner. Today we will discuss about trochanteric bursitis. While working as a physio with marathon runners, I was looking after their strength and conditioning. I was training them for an event called Comrades, which was supposed to happen in South Africa. It's an ultra marathon where runners are supposed to run for approximately 88 kilometers, which has a cutoff time for 12 hours. One fine day during a trial run, which was a half marathon, a male marathon runner suddenly had pain around the left hip joint while he was about to complete the run and was unable to put pressure on the same leg. On the spot treatment was done and icing was done around that area and then was brought to my clinic for the treatment. On examination, there was lateral hip pain, tenderness over and around the greater trochanter, pain at end range hip rotation, pain with resisted hip abduction and a positive Patrick fever. VAS scale was 7 or 8. Pain reduces on rest and worsens on movement. He complained of the inability to lay on the affected hip. There was absence of trauma. The nature of pain was nagging and sometimes dull aching. The duration of the pain was constant. The patient was afebrile. Attention should be paid to the position in which the patient keeps the hip while at rest. Patient with synovitis or a hip effusion will often keep the hip in a flexed, abducted and externally rotated position, as this position places the hip capsule at its largest potential volume. Test done in the standing, seated, supine and prone examination. In standing position, Trendelenburg gait is characteristic of abductor weakness. During the evaluation, the pelvis will drop on the contralateral side during the stance phase of the gait. The gluteus medius and minimus are not strong enough to keep the pelvis at level. As this weakness progresses, a compensatory shift of weight towards the affected side may occur. The next test was done in the seated position. The seated exam evaluates motor function, sensation, and circulation. Motor functions includes the assessment of muscles that are supplied by various nerves such as femoral, obturator, superior gluteal, and sciatic nerves. The next test was done in the supine position. While the patient is placed in a supine position, evaluate the hip range of motion with specific concentration on flexion, extension, adduction, and abduction. The internal rotation at the hip evaluates the stability of the pelvis with flexion in 90 degrees with a neutral abduction angle. The range of motion is dictated by a firm endpoint or by the patient's pain. There are specific provocative maneuvers that can enhance the physical examination. The first one is FADIR, the second one is superior lateral impingement test, third one is dexterate or DD test, also known as dynamic external rotatory impingement test or dynamic internal rotatory impingement test. The next one is Faber test and then the posterior rim impingement test. The next test was done in the prone position. The prone position is optimal for identifying the precise location of the pain, which is related to the SI joint, also known as sacroiliac joint, and assessing femoral anteversion. The next test is Craig's test, which is performed by flexing the knee to 90 degrees and while using the leg as a lever. The hip is internally rotated until the greater trochanter is felt to be the most prominent. Now we'll discuss about the treatment and protocols. For pain reduction and edema control, tissue magnetic stimulation and cryotherapy was used. For faster healing, laser therapy, and after 1 week, we started with shock wave therapy around that area. Myofascial release to iliotibial band and releases of the same were done. Releases of iliopsoas, quadriceps, then strengthening of the gluteus medius and all the muscles of the hips and knee. Dynamic neuromuscular stabilization, which was done in prone position and standing position. Then we progressed to proprioceptive training. Pain was reduced in 2 weeks, which was in 4 sessions. Follow-up after 1 month. As a result, runner was able to run in the Comrades and even completed it.